Thank you very much for those warm words of introduction, and we'll just wait for the slides to come up. So just to introduce myself, I'm Jalesh Panikar. I'm actually a neurologist with interest in neurogenic bladder, sexual and bowel dysfunction. In the next sort of 10 to 15 minutes, I'll be taking you through the impact of cerebral diseases on sexual functions. And that's my disclosure slide. So 55-year-old male, we start with a case who had a right-sided frontal infarct 6 months ago. Had a 10-day admission in a stroke unit, and then subsequently was shifted out. Managed conservatively. Risk factors identified has been sent home on a longer-term program of rehabilitation. So he had a left hemiparesis, and he's had a substantial recovery. He's back to work. He's regained much of his functions. The patient comes back to follow up with the stroke clinic, and everything seems to be fine. The patient could potentially be discharged. However, there's this little problem. So he's got a low sexual drive, he's got erectile dysfunction, very little sexual activity with his partner, and this is in contrast to a previously healthy relationship with sort of regular sort of sexual activity. So when we think of cerebral disorders, it's a heterogeneous sort of group of conditions. They can't really be classed together in the sense that they have different sort of etiologies, different sort of time courses. But you think of sort of conditions such as vascular disease, such as ischemia to the brain or a hemorrhage, where you have a sudden ictal event, where prior to that the patient was normal. After that, the patient there's a stage of abnormality with us, and after that, some degree of recovery that happens. But it's a one-off event as long as the risk factors have been addressed. And then you consider conditions of neurodegeneration, where there's sort of accumulation of misfolded proteins and depletion of different neurotransmitters, for example, Parkinson's disease, where you don't have a sudden ictal event. You have an insidious onset of different symptoms and signs, which can also include sexual dysfunction and sexual difficulties, and which gradually progresses as the neurodegeneration progresses. And then you have sort of different type of inflammatory conditions affecting the brain, such as multiple sclerosis or acute disseminated encephalomyelitis, different types of encephalitis. And these are probably the three most common cerebral disorders you'll come across in your practice. And of course, you can have traumatic brain injury, which is sort of similar to vascular disease, where you have a sudden event, and then you have changes in function, and following which there's a gradual recovery if the patient survives. And you have tumor, which has sometimes a subacute onset of events, and there's a progression of symptoms, and likewise, sexual difficulties can also progress, but often patients are left behind with quite a degree of residual dysfunction because of either the tumor or the treatment. And something epilepsy, which I won't be touching upon, which is actually rather complex, and you get rather different complex patterns of sexual dysfunction. And if we think about it, of course, we think about sort of the injury to neurons or to the white matter, and so the neuronal network that regulates sexual function has been damaged as a result of a loss of an injury. And this results in a loss of functions, which includes a loss of sexual function. But it's not just simple as that, because there are numerous other changes that are happening in an individual who's had a cerebral disease. For example, if there's a brain injury, trauma, for example, there could be damage to the hypothalamus and to the pituitary, and endocrine changes can occur from the brain injury, which can result in sexual dysfunction. As a result of brain injury, there could be concomitant sort of behavioral changes and cognitive changes. So there could be a whole host of psychological comorbidities, personality changes, a lack of motivation, changes in body image, all of these which can impact sort of sexual functions. We have medications. And then also you have to think about shared comorbidities. You think of the patient, the illustration earlier, who has had stroke. There are vascular risk factors such as high blood pressure, diabetes. The same vascular risk factors could be contributing to narrowing of the vessels in the penis and the corpus cavernosa, resulting in erectile dysfunction. So you have stroke in the brain, and you have vasculogenic erectile dysfunction. Or you think of the complex situation of epilepsy and erectile dysfunction, where often individuals with epilepsy have a host of psychological comorbidities, they have personality disorders, and it's not infrequent to come across erectile dysfunction in this group, which is more often a psychogenic erectile dysfunction. And of course, we had to think about, as Helmut mentioned, about the aging process, endocrinological changes with time. So you have the male and the female menopause, which can impact the process. Now, I'd like to point out this very obvious statement, but in clinic, it's sometimes we often forget, is that sexual dysfunction doesn't equate to erectile dysfunction, and we need to go back to basics, think about what are the different domains of sexual functions, thinking about sexual desire, thinking about sexual arousal, so becoming aroused and having an erection in a male, or having sort of vaginal wall or clitoral engorgement in a female with vaginal lubrication. We think about what happens at climaxing, so an orgasm, and in a male with ejaculation, and also we think about genital pain. So these are sort of fundamentals that all of you are aware about, but it needs to be applied in the case of a patient with a neurological disease as well. Now we take our patient, so post-stroke sexual dysfunction. This is a large cohort of patients from published a few years back from China, which and the commonest sort of symptoms that were reported are across the board: a loss of sexual desire, a loss of libido, reduced frequency of sexual activity, and reduced arousal, impaired orgasms, and reduced sort of sexual satisfaction. So all sort of domains of sexual functions are affected, as you can see, and in this study, plus many of the studies affected both in men and women. Now, what I would like to add, however, is that sexual dysfunction can persist. And if we look at sort of sexual desire, this is 2 months after the stroke, and this is 6 months. You find that the figures are comparable. And so, and in this cohort of patients, actually, they had very little disability neurologically at 6 months. However, as you can see, there's not at all an improvement in this domain of sexual functions. And you look at sort of in the male patients with erections and their ability to ejaculate. Once again, look at the figures at 2 months, compare at 6 months for erections and for ejaculation. As you can find, even at 6 months, despite a recovery in neurological deficits, these patients still have ongoing problems with sexual difficulties. And we also look at, and as a result, as you'll find, the frequency of sexual activity also remains low. So this is sort of the baseline before the stroke, based on historic data. But then you see following the stroke, 2 months and 6 months, not a significant difference. So the profile of the patient that you saw earlier is quite typical of the patients that you will come across in clinic. And this has actually been sort of explored, and this is a large cohort of 170 patients from Finland, which looked at sort of the factors that could be contributed to persistent decline in sexual activity. And there are different factors that one could find. The general attitude towards sexual activity, sexuality, is actually remains low at follow-up. A fear of actually being impotent without actually trying it out. An inability to discuss problems of sexuality with the partner or even with the healthcare professional. An unwillingness to participate in sexual activity. This study showed that there was a correlation with the degree of functional disability. And also in this study, they looked at the spouses. And their spouses reported a significant decline in libido and also sexual satisfaction in the study. And there are studies that show that the level of independence does correlate with the decline in sexual activity, the onset of sort of psychological disorders such as depression and anxiety. There's a fear after having had a stroke that sexual activity can sort of precipitate a new stroke. If there's a use of an antihypertensive, either with the fear that sexual activity can increase the blood pressure, or the use of beta blockers, which are a mainstay of treatment for hypertension, which can affect erectile functions, and psychological factors, a perceived loss of identity following the stroke, a shift in the gender role. And importantly, in this study that sort of looked at questionnaires, administered questionnaires, and also interviewed caregivers, this conflict of a caregiver previously being a sexual partner who's now a carer, and this is conflicted with the sexual needs afterwards. But what's interesting is that there's no association with the type of stroke that's been found. Now we changed gears to a neurodegenerative condition, and we talk about Parkinson's disease. Now, dopamine plays an important role in sexual functions and health, which Bertel might touch upon in his talk. But essentially what you find in men and women after Parkinson's, who have Parkinson's disease, is considerable morbidity from sexual dysfunction, affecting different domains of sexual functions, as you can see. And different studies studying at different time points in Parkinson's disease have given a consistent sort of a pattern of sexual difficulties. Only thing is that the prevalence seems to increase as the duration of Parkinson's increase, as well as the degree of disability. Also, it's known that the age of onset of the Parkinson's disease, the female gender, lower education, and the presence of psychological comorbidities once again can influence libido. What's particularly important for Parkinson's is bed separation, because many of the patients with Parkinson's have violent dreams that we call REM's, sleep behavior disorder, and so the partner is unable to sleep with the individual in a separate bed or even in a separate room. Also, the problem of nocturia. The patient gets up several times a night, and it disturbs the partner's sleep. So there's not an opportunity to actually come together, and it isn't sort of a conducive environment for intimacy. So this comes to this emerging view that when we talk about sexual difficulties in cerebral disorders, that is actually it's multidimensional. So we think about the primary neurological lesion, of course, but we have to think about the secondary sort of factors that can be contributing. So you have a patient with a neurological disease. As a result, they can have problems with spasticity in their limbs, they can have weakness, they can have fatigue, they can have problems with coordination of their hands, difficulties in attention, and they can have bowel and bladder incontinence, all of which can affect intimacy and sexual activity. And then we think about the tertiary factors that can influence sexual activity, such as the psychological comorbidities, the change in body image after a cerebral disorder, and the changing role of the partner in the relationship from being a sexual partner to a carer, and the change in the family role. Now, medications play an important role, and in this one list I just want to highlight the antimuscarinics that we use for the bladder can cause problems such as vaginal dryness, but many of the medications such as gabapentin, which is ubiquitous in any patient with a neurological disease, can impair erectile functions. What I would like to highlight is SSRIs, because I believe that this is going to be the next scandal after the opiate scandal. SSRIs are once again something that's seen on every prescription of a neurological patient, but it's associated with quite a degree of sexual dysfunction. The pattern is quite distinct. So in men, it's erectile dysfunction, but you have loss of genital sensations and problems of orgasms. And in women, once again, genital anesthesia. So it's a particular pattern of sexual difficulties you see in SSRI exposure, which is distinct from neurogenic sexual dysfunction as a result of a neurological lesion. And amongst the SSRIs, drugs like citalopram, paroxetine, sertraline are the top drugs that cause the problem, whereas medications such as venlafaxine and mirtazapine, which is not on this list, the incidence of sexual dysfunction is less. I'll briefly touch upon hypersexuality in a minute because I think it's quite important. And many of you might be aware that in your Parkinson's patients that you see, a percentage of them have what's called impulse control disorders, and they have problems with pathological gambling, compulsive sexual behavior, compulsive buying, and this is a result of their degeneration and supplementation of the dopamine medications. So it's a small percentage of patients, but they have sort of compulsive, repetitive, sort of reward-based behaviors. It can be akin to sex addiction in a young individual who doesn't have Parkinson's, but the phenotype is quite similar, and it's associated with the use of the PD medications, and the treatment is actually to reduce these medications. Now, in contrast to this, the other group of cerebral disorders are conditions with disinhibition, such as with dementias, where what you have is hypersexuality, but in the context of inappropriate sexual behavior, more in individuals who are institutionalized, and it's associated with a disruption of frontal lobe executory functions. You can read the profile of hypersexual behavior that's there. What I would like to highlight is extremely difficult to recognize in clinic. And so over the years, there's sort of some very subtle tips that I've picked up. And one is the patient who comes in requesting more Viagra, despite having had very good effects with their dosage of sildenafil. They're dissatisfied with the sexual performance. And if you start getting that history, you need to question further. The second is from the caregiver burden, is a partner whose eyes rolls up when the patient says, I have erectile dysfunction. When you see that, you need to somehow get the partner separately and start asking about this. And lastly, is a partner who says, I need to talk to you for a moment, takes you out of the consultation, and in the corridor tells you about this problem of hypersexuality. So in conclusion, sexual dysfunction in this context of cerebral disorders is common. I would like to highlight that it is there are multiple domains to be asked about. It's a multidimensional problem, and one must inquire about not only sexual dysfunction but sexual activity, but also about premorbidly, how the relationship was, and about sexual functions in general. Thank you.
Good evening, ladies and gentlemen. Here we are about this basic science, and so we have, I think, a nice new study regarding treatment of bladder dysfunction. I think you can start with the first presentation. Please take.
So, super. It's welcome, everybody, and thank you for coming. So we're going to learn now about gene therapy with herpes simplex virus vectors and mutant glycine receptors. Dr. Suzuki. Thank you.
I'm Shimizu.
Sorry. Doesn't say that here, so I apologize.